So if you break your arm, the X-ray is pretty binary, right?
Oh, entirely. Yeah.
You see the jagged white line, you cast it, it heals, and you move on. But when you step into the world of postpartum recovery and female sexual wellness, that comforting diagnostic clarity just it completely vanishes.
It really does. It's a remarkably murky landscape.
Right. Because a tiny, seemingly localized scar from childbirth can actually act like this internal winch. And 5 years later, it's completely altered the architectural angle of a woman's internal organs.
Which is wild to think about.
It is. And as we'll see, it can totally sabotage modern sexual wellness procedures.
So welcome to another deep dive. Today, I've got a really fascinating stack of sources to go through with you.
Yeah, we're looking at some incredible clinical data today. MRI-based anatomical studies of the vaginal axis, clinical trials on hyaluronic acid and PRP injections.
And even some very specialized urogynecological physiotherapy guides.
Mm-hmm.
Exactly. And, it challenges the way we traditionally view human anatomy. We have this tendency to treat the body as a collection of, isolated compartments, right?
Yeah, exactly. You have a scar over here, and you experience a loss of sensation way over there, and the default assumption is that they have absolutely nothing to do with each other.
Right. But these sources prove that the pelvic floor is this highly interconnected ecosystem. A single altered tension line in one corner changes the physics of the entire environment.
Which brings us to our mission for this deep dive. We are figuring out how an old scar, from an episiotomy or a perineal tear, actually alters the physical angles of the pelvis. And crucially, why that architectural shift directly impacts a woman's ability to experience pleasure if she, say, decides to get a G-spot augmentation later on.
So to really understand those downstream effects, we have to look at the biology of the initial injury.
Right. The inciting incident.
Yeah. When we talk about a natural perineal tear or a surgical incision during birth, we are looking at significant tissue trauma. And the body, it immediately rushes to patch that structural deficit.
But it doesn't just heal back to factory settings, does it?
No, not at all. Healthy pelvic tissue relies really heavily on type 3 collagen.
Okay.
And type 3 forms this beautiful elastic reticular network. It stretches out, it absorbs force, and then it just snaps right back.
Like a good rubber band.
Exactly. But during the rapid wound healing phase, the body doesn't have time for that. So it replaces it with type 1 collagen.
Which is different.
Very different.
Yeah.
Type 1 is incredibly strong. I mean, it's the primary component of our tendons, but it is rigid. The fibers align in these parallel, really thick bundles.
So it's essentially physiological duct tape.
That is the perfect way to describe it, yes.
Yeah.
Physiological duct tape. So the healed perineal tissue, it never fully regains its original elasticity or its precise resting length.
I always picture it like a perfectly balanced suspension bridge. Or actually even simpler, a tightly fitted bed sheet on a mattress.
Oh, I like the bed sheet analogy.
Right. The tension is supposed to be distributed flawlessly across all four corners. But if you pinch one corner of that sheet and sew it together with rigid thread, the entire structure pulls completely out of alignment.
Yeah, you see those deep tension creases radiating outward.
Exactly. The sheet doesn't just sit wrong in that one corner. The very center of the bed is now totally skewed. And the biomechanical studies we're looking at put some staggering hard numbers to this architectural butterfly effect in the pelvis.
They really do. When that dense type 1 collagen scar forms, it actually contracts over time. And that can cause a 30% to 50% reduction in the length of the perineal body.
Wow. Up to 50%.
Up to 50, yeah.
Yeah.
And this shortening is what acts like that winch you mentioned earlier. It physically pulls on the deeper fascial structures.
Which throws off the whole geometry.
Right. It dramatically increases the inclination of the levator plate by about 15 to 25 degrees.
So gravity and abdominal pressure are suddenly hitting the internal organs from a completely different angle.
Precisely. And the surrounding muscles simply cannot handle that redirected load. The sources describe this as initiating what they term a biomechanical vicious cycle.
A vicious cycle. Because things just start failing.
Yeah. The increased strain frequently results in concurrent levator plate avulsions.
Okay, an avulsion. That's where the muscle actually tears away from its anatomical attachment point on the pubic bone, right?
Unfortunately, yes. It rips right off the bone, almost always at the 3 and 9 o'clock position.
Yeah.
Because that's where the mechanical stretch is maximal when the baby is descending.
Gosh, so if the muscle is tearing away from the bone, the structural integrity of the entire pelvic basket is compromised?
Severely compromised.
Yeah.
Those avulsions reduce the contractile efficiency of the pelvic floor by up to 60%.
So the normal support system just fails.
It fails. So instead of the vaginal canal sitting at its normal physiological angle, which normally is roughly 90 degrees relative to the surrounding structures, the path of least resistance changes.
Because the support is gone.
Right. The physical collapse of the levator plate basically drags the vagina backward. It tilts it into a pathologic angle of about 120 degrees, give or take 10 degrees.
Wow, so that normal 90-degree angle becomes 120 degrees. The foundational fitted sheet of the pelvic floor has literally been stretched and dragged backward.
Yeah, the architectural foundation is essentially sunk.
And if the foundation has sunk, the layout of the entire house changes.
Exactly.
So let's look at what this means for the specific landmarks inside, particularly the destination that so many women focus on for sexual wellness, which is the G-spot or the Grafenberg spot.
Right, which we should clarify isn't just a distinct localized little button.
Right, it's not a button. The clinical literature actually maps it as an area roughly 1 to 3 inches deep, highly dependent on the surrounding architecture.
Yeah, it's an ecosystem. It's often referred to in the literature as the clitorithrovaginal complex.
The clitorithrovaginal complex. So it's basically the overlap of the urethral sponge, the internal erectile tissue, and that massive density of pelvic nerves.
Right. It's a highly sensitive crossroad.
And knowing this crossroad exists, the whole field of aesthetic gynecology has kind of exploded with procedures like G-spot augmentation or, the G-shot.
Oh, it is a booming sector of aesthetic medicine right now.
Yeah. The clinical trials we're looking at, they detail doctors injecting specialized cross-linked hyaluronic acid brands like Deserial, Armonia, or Novia Rose. Or they're using a patient's own autologous fat combined with platelet-rich plasma and injecting that directly into the vesicovaginal septum.
And it's crucial for you to understand the physics of why they use those specific materials. Because hyaluronic acid, it naturally occurs in the body, but it breaks down in a matter of days.
Right. It wouldn't last long enough to do anything.
Exactly. So to make it last, pharmaceuticals use chemical cross-linking. They bind the long chains of acid together into a dense 3D mesh.
So they're turning a rapid-absorbing liquid into a structural gel that holds volume.
Yes. You're permanently modifying the architecture.
Well, temporarily, right?
Temporarily, yes. But on a structural level, you're changing the mechanics. The physiological goal is entirely about mechanical advantage. By injecting this dense matrix, they increase the thickness and the volume of the urethrovaginal space.
Which makes the tissue project lower into the vaginal canal.
Exactly. It alters the friction plane. The theory is that this modification allows for much easier mechanical stimulation during penetrative sex, theoretically enhancing arousal and the potential for climax.
Okay, wait, hold on. This is where the logic seems to completely fracture for me, based on what we just talked about.
Okay, let's hear it.
If a doctor performs a standard aesthetic augmentation, they are relying on textbook anatomy. They are assuming a 90-degree baseline angle, right? But if you have that rigid type 1 collagen scar from earlier, and it acted like a winch and pulled your pelvic anatomy back to 120 degrees, does the augmentation just miss the mark entirely? I mean, they'd be injecting expensive filler into a target that is geographically moved.
That is the exact critical collision course this data reveals, and the MRI evidence absolutely validates your realization there. The target has physically migrated.
Wow. So if the angle shifts 30 degrees, I have to imagine medical imaging shows the augmentation landing in completely the wrong physical location.
It does. It really does. When radiologists map this out, they use a specific reference line to evaluate the normal position of the upper two-thirds of the vagina.
Okay, what's the line called?
It's known as the PS3L. It's an imaginary line drawn from the inferior pubic symphysis all the way to the midpoint of the third sacral vertebra.
Got it.
In a healthy pelvis, the upper two-thirds of the vaginal axis runs beautifully parallel to this PS3L line.
So if it's deviating from the PS3L because of the scar tissue,
then the entire anterior wall is pulled backward and upward. The MRI data clearly shows that with pelvic floor dysfunction in a shortened perineal body, the vaginal axis deviates sharply from the PS3L.
Which means the G-spot, the clitoretrovaginal complex, is physically displaced from its optimal friction point.
Exactly.
So a doctor could execute a technically flawless G-shot injection, putting the cross-linked hyaluronic acid exactly where the complex should be in a textbook. But because the patient's entire pelvic architecture has collapsed backward, penetration during sex just glides right past it.
It misses it. The mechanics of friction are totally broken at that point.
That is wild.
And it's often made actively worse. because the geographic displacement, that's only half of the equation.
There's more.
Yeah, we also have to look at the health of the tissue itself, which brings us to a concept called hypertonus dysfunction.
Okay. Hypertonus. So the muscles are essentially locked in a perpetual state of guarding.
Right, because a rigid perineal scar doesn't just sit there passively. It actively irritates the nervous system, which causes the surrounding pelvic floor muscles to go into a continuous, involuntary spasm.
They're constantly clenched.
Yes, they're trying to protect the injured structural weakness. And mechanically, that constant contraction is catastrophic for cellular health.
Because it's acting like a tourniquet.
Exactly like a tourniquet.
Yeah.
When the resting tone of a muscle remains that high for years, the intramuscular pressure actually exceeds the capillary perfusion pressure.
Meaning blood physically cannot enter the tissue.
Right. It creates a state of severe hypoxia, oxygen starvation.
And if the tissue is starved of oxygen and blood flow, the nerve endings aren't going to function properly anyway.
They misfire completely. The lack of oxygen, combined with the buildup of metabolic waste products in the tissue, it alters how the nerves signal the brain.
So what does that actually feel like for the patient?
It creates this paradoxical state where the tissue becomes simultaneously numb to light touch, but intensely hypersensitive to pressure or pain.
Wow. And here's the tragic irony of this entire process. A woman might experience a loss of sensation during sex, which makes perfect sense given the hypoxia and the displaced 120-degree anatomy.
Right.
So she seeks out a G-shot, hoping to reclaim that pleasure. But if you add dense volume to a starved, rigid, misaligned space, the friction against that augmented wall isn't going to register as erotic stimulation.
No, it's going to register as physical trauma. It leads directly to dyspareunia, painful intercourse.
That is heartbreaking. The intervention meant to enhance pleasure ends up exacerbating her pain.
Because you're adding mechanical stress to a system that is already failing.
It's like trying to reinforce a load-bearing wall when the foundation of the house is already sunk into the ground. You're just putting more weight on a collapsed structure.
That structural analogy is spot on again. You cannot optimize the furniture until you fix the foundation.
Okay, so let's pivot to the solutions, because we want to ensure you don't feel like this is a lost cause. If this architectural collapse is the root cause of the pain and the numbness, how do we fix the foundation? Can that 120-degree angle be reversed without putting the patient through yet another invasive surgery?
The clinical data is actually incredibly optimistic here. We can reverse this.
Really? How?
Through specialized urogynecological physiotherapy. Specifically, perineal scar rehabilitation. The main goal is to remodel that rigid type 1 collagen.
And the hands-on approaches detailed in the research are remarkably practical. One of the core at-home treatments mentioned is just perineal scar massage.
Yes.
They recommend using a water-soluble lubricant and just tracing circular motions directly over the scar tissue for like 5 to 10 minutes a day.
And mechanically what you're doing there is forcing fascial glide.
Right. You're getting the layers of tissue to slide over each other again instead of acting like they're glued together.
Exactly. You are physically stretching those parallel type 1 collagen bundles. And furthermore, the sustained mechanical friction overrides that tourniquet effect we talked about.
It forces the blood back in.
Yes, localized vasodilation. It pushes fresh, oxygen-rich blood back into the hypoxic tissue. That flood of oxygen helps clear out the metabolic waste and actually desensitizes those hyperactive nerve endings.
That's amazing for an at-home treatment. But manual massage is just the baseline, right? The high-tech interventions detailed in the physiotherapy guides are where the physics really get fascinating.
Oh, absolutely.
Like shockwave therapy, specifically using devices like the V-Actor for vibrational therapy.
Yeah, shockwave therapy is a massive leap forward for pelvic rehabilitation. It utilizes high-energy acoustic waves, and they're just applied externally to the perineum.
So break down the physical physics with that for a second. How does a sound wave fix a physical rigid scar?
So when these high-energy acoustic pulses propagate through the dense tissue, they create rapid fluctuations in pressure. And this causes these tiny microcavitation bubbles to form and instantly collapse within the intracellular fluid.
Wow.
Yeah, and the sheer mechanical force of those tiny implosions physically breaks apart the rigid, deep-seated cellular adhesions that human fingers simply cannot reach.
So you're literally shattering the physiological duct tape at a microscopic level.
You are. And the secondary benefit is just as crucial. The microtrauma from those shock waves triggers the body's natural healing response all over again.
But this time it heals correctly.
Right. It promotes angiogenesis, which is the creation of entirely new capillary blood vessels. It floods the area with vascular support and stimulates the fibroblasts to start producing healthier, more elastic collagen fibers again.
So you're rebuilding the suspension bridge's elasticity.
Precisely. And when we combine this acoustic therapy with manual mobilization, we achieve what researchers call dynamic biomechanical equilibrium.
Dynamic biomechanical equilibrium. You are unpinching the corner of the fitted sheet.
The winch finally releases. As the perineal body lengthens back toward its natural state, the mechanical tension on the pelvic floor just drops.
And the levator plate lowers from that severe 25-degree tilt.
Exactly. The muscular spasms finally cease.
And as a direct result of all that, the vaginal axis physically shifts from that pathologic 120 degrees back toward a healthy 90 degrees.
Right, realigning beautifully parallel to that PS3L reference line we talked about.
The architecture is completely restored.
It is.
And that is when an intervention actually makes sense.
Right.
Only when that dynamic biomechanical equilibrium is restored and the pelvic stress vectors are normalized can a procedure like a G-shot actually thrive.
Yes, because now if you inject that cross-linked hyaluronic acid into the clitorethrovaginal complex, the tissue is pliable.
It's vascularized.
And most importantly, it's geographically in the right place. The intervention aligns with the anatomy rather than fighting against it.
It is such a powerful illustration of how our bodies function as these deeply interconnected webs of tension.
It really is.
I mean, we started this deep dive looking at a single isolated childbirth scar. But by following the biomechanics, we traced how that one local injury shortens the perineal body, winches the levator plate, tilts the entire vaginal axis, and ultimately creates a hypoxic environment that totally sabotages modern sexual wellness procedures.
It forces us to recognize that structural integrity dictates physiological function every single time.
And it completely changes how we should look at preventative care.
It does. In fact, if we look at the broader implications of these biomechanics, it introduces a really fascinating thought to mull over.
Oh, I'm ready for it.
We've established that a single, localized scar can pull the pelvic floor 30 degrees out of alignment, eventually causing this profound architectural collapse, right?
Right. Over time, the tension ruins the structure.
So what if the future of postpartum care isn't just a basic visual checkup? What if it involves routine 3D MRI mapping to inspect a mother's pelvic stress factors immediately after birth?
Oh, wow. Treating the human body with the same preventative structural engineering we use for bridges.
Exactly. Catching the altered tension lines long before the symptoms of collapse ever even appear.
That is an incredible framework for the future of medicine, treating the tension before it breaks the system. Well, thank you so much for joining us on this deep dive. We really hope this exploration empowers you to keep questioning the incredible, invisible architectural connections within your own body. Until next time.